I would like to thank Professor Abrinodaki and the organizing committee for inviting me. I'm going to speak in English. Is that okay? Or I can speak Greek too, so whatever you like. So the question is, the topic of my talk is customizing hormonal therapy in the context of ovarian, endometrial, and breast cancer, and kind of like modified it, saying customizing hormonal therapy in the context of gynecological cancer, because I'm going to talk a little bit about cervical cancer as well, because there's some data, not a lot of data, but some data. So when we're talking about HRT, we're talking about estrogens plus or minus progesterones. You can give it orally, you can give it transdermally, you can give it as a gel, you can give it as a vaginal ring, you can do an IUD. You can give it sequentially, or you can give it continuously. There was a discussion before about testosterone. I'm not going to talk about it, but I know Dr. Samaras likes testosterone, so I'll just put it there for him. And I would like to set the basics of the discussion. The basics is that most studies on HRT refer to women with natural menopause. These are the huge studies, the WHI study, the HERS1, HERS2 studies, and etc. Little is known about women with iatrogenic premature ovarian failure, and even less is known about women with iatrogenic primary ovarian failure due to cancer treatment. And the question is, what do we need HRT for these women? Of course, we need HRT to treat menopausal symptoms because these women are suffering for hot flashes, they have vaginal dryness, to prevent bone loss, to reduce the risk of colorectal cancer, to reduce the risk of Alzheimer's disease, to reduce cardiovascular risk. And I put a question mark there because there's a huge debate when you started what you do with it. But of course, there are risks. And the risks are the thromboembolic disease and strokes, and the transdermal way of giving hormone replacement is better than the oral. Increased incidence of gallbladder disease, and of course the impact on breast, endometrial, and ovarian cancer. So looking at gynecological cancer, we're going to look at the breast cancer. In my talk, we're going to look at ovarian cancer, look at the data on endometrial cancer, cervical cancer, and we're going to talk about the hereditary cancer syndromes and risk reduction surgery, as was discussed before. It's kind of interesting to see that, of course, breast cancer is the most common gynecological cancer, and we think about it as a cancer of a kind of like older woman. But if you look at very carefully, you see about 1/5 of women develop cancer before the age of 54, and 2% of women develop breast cancer before the age of 44. And kind of interesting, you have 2% of less than 34. So you have some young women. It's not a big percentage, but if you look at that, if you think that this is the most common gynecological cancer, how many women suffer with breast cancer? This is a big number of women that will develop breast cancer, and they will need to be treated for breast cancer at a very, very young age. And this is actually what we care about. Looking at genetic risk for breast cancer, of course, 20 to 25% of breast cancer patients have a positive family history. About 5 to 10% of these patients will demonstrate an autosomal dominant inheritance type. And the lifetime breast cancer risk ranges from 65 to 80% for BRCA1 mutations carriers and 45 to 85% for BRCA2. And of course, we have other genes that can confer a moderate risk for breast cancer, about 20 to 40% lifetime risk, and this has to do with mutations in the ATM genes, with somatic mutations for the CHEK2 genes, and also for BRCA1, BRCA2 related genes, modifier genes, so like the BRIP1 and BAP2. And if you look at breast cancer, apart from surgery, we do have chemotherapy. And chemotherapy can be quite toxic, because if you look at the protocols, these are from the most recent guidelines from the NCCN. They include agents that are very, very toxic for the germline. They are very toxic because they are chelated agents like cyclophosphamide, doxorubicin, FU, and these are agents, especially if you do high-intensity protocols, that they can, we can be sure that a good percentage of these women at the end of their chemotherapy will go into menopause. So there's a real problem for young women developing cancer that they need to take chemotherapy. And these are different protocols. We don't really care about it, but the bottom line is that this treatment sometimes might be quite toxic for the gonads. Looking at HRT and breast cancer, unfortunately, things don't look very good. There were two big trials that started almost at the same time in Sweden, and prospective randomized trials designed to evaluate the impact of hormone replacement therapy in women that have iatrogenic menopause after treatment for breast cancer. And the question is whether these women have increased risk of recurrence of the disease. The first trial is the Hobbits trial. The second trial was the Stockholm trial. And unfortunately, after 2 years of follow-up, both the trials have to be stopped because in the interim safety analysis, the first trial, the Hobbits trial, the risk of developing recurrence of having a recurrence of their disease was significant. Therefore, the other trial, the Stockholm trial, was also discontinued, despite the fact that it was different. The design was quite different, and the dose of progestogen, if you wish, was different in these two trials. Just to give you an idea, this is from the interim analysis, about 2.5 years of follow-up, and you can see, I don't know if you can see my pointer there, but I can show you here. No, I cannot. I have the mouse, okay. All right, great. And if you see here, these are the relative hazard for women that took HRT and they had breast cancer, 3.5 times higher chance of developing a recurrence. And if they were hormone receptor positive, were much higher. If it was hormone receptor negative, were lower. But overall, they have 3 times higher chance of developing breast cancer. There were 26 cancer cases in the HRT group, and there were 27 and 6 cases of recurrence in the non-HRT group. So that was actually the kiss of death for this trial, which also gave the kiss of death for the Stockholm trial, which at that time did not show an increased incidence. And this is actually a follow-up on this patient. And as you can see here, this is the HRT group. Sorry. This is the HRT group, and you can see they have, there was a longer follow-up, 4.5 years follow-up, and you can see the risk of recurrence in this woman that took hormone replacement therapy was significantly higher than the woman who did not take hormone replacement higher. And you can see it here that there was a trend of increasing this, the chance of recurring. And when they looked at, there was a difference whether they were taking this hormone replacement orally, continuously, transdermally. Actually, there was no difference. If they would take it, they have increased risk of developing a recurrence. This is from the Stockholm trial, and as I mentioned before, in the first 2 years when the study was discontinued, at that time the Stockholm trial did not show an increased risk. Actually, has showed a trend for reduction of breast cancer. But if you look at from this publication in a few years ago, at that time they had 10 years follow-up, and at that time the risk was still not significant, but there was a trend for increase, 1.3. Still not significant, but there was, as you can see here from the graphs, there was an increase of risk of recurrence even in the Stockholm trial. So to make a long story short, there's not much future for giving HRT in women with breast cancer. And this is important because women with breast cancer is the vast majority of women that they have iatrogenic premature ovarian failure due to their cancer. So if we don't have hormone replacement therapy, then we have to think how we're going to deal with other postmenopausal symptoms such as hot flashes. I forgot to mention that there was a slide that I don't have it here. There were some studies looking at vaginal estrogens for these women. Apparently, the data are still conflicting. There are not enough data, but the official recommendation from the American College of Obstetricians and Gynecologists is that you can give vaginal estrogen in terms of gels or whatever you want to give, but still with the caution and under informed consent, and providing that all the other issues, all the other non-hormonal agents do not work for these women. There are women with severe vaginal atrophy that affects their personal life, affects their marital life, and they said, that's enough, I just want to try it, and I will take a small risk. Regarding hot flashes, basically SSRIs have been used, different SSRIs in several randomized trials, and actually they seem to work. But there's a little problem here, that if you look at specific SSRIs, they induce, if you look actually at the pharmacology of tamoxifen, to be more active has to be transferred to endoxifen. There's a special cytochrome there, and some of the SSRIs block this cytochrome, the cytochrome P450, therefore eliminating the active form of tamoxifen, and therefore can have an effect on the pharmacological impact. And it seems that citalopram and venlafaxine are the ones that are more friendly to the cytochrome and should be used, compared to fluoxetine, paroxetine, that they are strong inhibitors, and therefore they can reduce the efficacy of tamoxifen. Clonidine has been used for hot flashes. Gabapentin has been used for hot flashes. Vitamin E has been used for hot flashes. Phytoestrogens, a big discussion. You are more expert than me in phytoestrogens. Basically, I think it's a placebo effect. Nobody knows, but some people are happy with that, and I'm happy to prescribe them if they like them. So I'm not going to go into more detail for that. Ovarian cancer. The previous speaker elaborated a lot on this topic. The highest mortality of all gynecological cancers, and the overall 5-year survival is still about 45 to 50%. Epithelial ovarian cancer accounts for more than 90% of the malignancies. Germ cell tumors, sex cord stromal tumors, younger women, but only 5%. But still there's a significant proportion of young women that develop ovarian cancer under the age of 40. About 3 to 17% are under the age of 40 at the time of diagnosis. And there are some follow-up, especially the larger study I found is from one of my friends and colleagues. He's the head at the University of Larissa. This is a study from South Africa, when he actually randomized women given after ovarian cancer, premenopausal women with ovarian cancer, into hormone replacement therapy. And apparently they did not were able to document any increased risk in recurrence of the disease. And this actually from all the studies that I was able to found in the literature, and you can see these are estrogen therapy, and we're talking about now not hormone replacement therapy, we're talking about estrogen therapy. There's no point of giving progesterone to these people since they had a hysterectomy. And as you can see, apparently there's no increased risk of recurrence. And as you can see here, overall, all the studies did not show any increase of recurrence, and actually they see some survival benefit for these women. I'm not going to go a bit. And actually, when they're analyzing this meta-analysis according to the stage of the disease, still they didn't, estrogen replacement therapy did not have any impact in the risk of recurrence, whether it was early stage ovarian cancer or late stage ovarian cancer. Again, you can see here, this is also for the assignment. You can see that this is the control. The survival rates actually are significantly better for women that had ovarian cancer and they took hormone replacement therapy, which actually confirms all the data that hormone replacement therapy might confer other benefits in terms of survival. So talking about estrogen replacement therapy after ovarian cancer, there's no survival difference regardless of disease stage. When we look at sex cord stromal tumors, they have no hormone receptors. They occur in young women, and of course they can take HRT. For stage 1 and fertility sparing surgery, they can have HRT. Germ cell tumors can receive HRT. So things look much better for ovarian cancer. Endometrial cancer, the most common cancer, as was presented before, it is very common in postmenopausal women. However, about 1/4 of women with endometrial cancer will develop endometrial cancer in their premenopausal years, and 5% of these, 5 to 10% of these women are younger than 40, meaning that their treatment will require some measurements because these women will have iatrogenic ovarian failure. And these are the biggest study was from Sloan Kettering by Baraka, 618 patients, and these women were, after surgical treatment, went on hormone replacement therapy, and apparently there was not increased risk or recurrence. So, if you look at endometrial cancer, about 70 to 80% of women are cured by surgical treatment. The risk of recurrence in stage 1 disease is about 1 to 3%. There's no increased risk of recurrence in women given estradiol in this group. There are some old studies by Grisman back in the 80s and 90s that show that these women who had surgical treatment for endometrial cancer then took estrogen have improved survival and, of course, better quality of life. And for G3, for poorly differentiated endometrial cancers, there's still some debate, but overall things are not that bad. Cervical cancer is the second most common malignancy, and of course it's causes significant morbidity and mortality, especially in developing countries. And just to give you an idea that cervical cancer is a disease that has two different peaks and can often occur in younger women. Of course, the standard of care for this woman is radical hysterectomy with preservation of the ovaries. Therefore, for a proportion of these women, there's no issue of hormone replacement. However, occasionally you might need to remove the ovaries, or they have to take radiation. And I can reassure you, even if you transpose the ovaries, then it's not sure that you're going to protect them from the adverse effect of radiation. Therefore, there's an issue about this woman. The most common cervical cancer type of tumors are squamous cell carcinomas, which is about 80%. And you have the remaining, which is about 15%, which is adenocarcinomas. And there's some issues about whether hormone replacement can have some effect in adeno-CAs. But however, things, and again, the data are not, we don't have a plethora of data, but what we have so far shows that there is not increased risk from hormone replacement after surgical treatment for cancer of the cervix. And these are the data. The biggest series back from, you can see here, from 1987. So things also look good for cervical cancer, and I think most of us, and we have our colleagues, GYN oncologists here, will not hesitate when they operate on a woman who has cervical cancer to give her hormone replacement, estrogen replacement. What about BRCA carriers? Big discussion about BRCA carriers. The lifetime risk of developing cancer in the general population is 1.5 to 1.8%. In BRCA1 and BRCA2 carriers, about 60%. The issue here is that there's a different time when the breast cancer shows up in this woman and a different time when the ovarian cancer will show up. So by 40 years of age, the risk of breast cancer in BRCA1 or 2 mutations is approximately 20%. But if you look at the age of 40, if you have BRCA1, your chance of developing ovarian cancer is only 3%. If you have BRCA2, it's very, very, very small. If you look later in life, the risk of ovarian cancer increases by 40% at 50 years on in BRCA1 carriers, whereas the risk of ovarian cancer in BRCA2 carriers exceeds the limit of 10% after the age of 60. Meaning that if you have BRCA2, you can buy some more time before you develop ovarian cancer. And that is significant when you're counseling your patients, and because it's not the same thing, BRCA1 and BRCA2, but you have probably to fine-tune and see where exactly is your issue and what are the risks according to the mutation, according to the age, and of course according to what is your desire, the desires of fertility for this particular women. Overall, oral contraceptives, I'm not going to spend a lot of time on that. I know you we ran out of time, but basically this is the best thing we have to prevent to reduce the incidence of ovarian cancer either in a high-risk group or in the general population is taking birth control pills. And I'm not going to elaborate more on that because it was discussed before. The same thing you can see here for breast cancer. You see because the discussion is, you know, there are some studies showing that if you give birth control pills, we know it's going to reduce the risk of ovarian cancer, but also we know it might increase a little bit the risk of breast cancer. It's like a give and take situation, a catch-22 situation, and you have to figure out how you're going to discuss that with your patients. I'm not going to go to osteoporosis, but basically the thing is, it's very important that you have to figure out in this woman, especially women with genetic risk for ovarian cancer, that they have to have oophorectomy very early, especially after they complete their childbearing, if you wish. If they are BRCA1, they have their kids, and then, you know, they said that's enough. What you're going to do about that, and how you're going to manage with these women in terms of osteoporosis. And basically, you need to, they need to take something, because the risk of osteoporosis, especially in that young age, with this life expectancy is very, very high. So I would like to conclude. The main indication for HRT remains severe post-menopausal symptoms that interfere with daily life. HRT can be used in endometrial cancer survivals, cervical cancer survivals, ovarian cancer survivals. For carriers of BRCA1, BRCA2, oral contraceptives, which actually, if you look at from the hormonal point of view, or the synthetic estrogen is 5 to 7 times more potent than 17-beta estradiol, because it's ethinyl estradiol, which is much more potent. So the estrogenic effect is significantly higher. The best type and duration of treatment is still unclear, and unfortunately HRT is not recommended for breast cancer survivals, and we have to find alternative methods to treat these menopausal symptoms. I would like to close here by just going back to my favorite topic. We have a big interest on women, on fertility preservation in women with cancer, and this is actually our society, the Hellenic Society for Fertility Preservation, which is something that we need to, like to work on and focus on this issue, because I believe a lot of women are not informed about their options. For example, we can talk about oophorectomy and ovarian and egg freezing with preservation of the uterus, because that's another option. You have a woman with BRCA1, she can have her oophorectomy, she can have mastectomy, she can freeze her eggs, and then later on she can have her children. So you give more options to these women. It has to be discussed. And I would like to thank with my favorite Englishman. Thank you very much for your time.